Good morning and welcome to our monthly webcast. I'm Samir Mehta, your moderator. This is session number 192. We complete 16 years of uninterrupted CCC live cases with what, if I was to name our single biggest contribution, absolutely no conflict of interest cases done only for the benefit of the patient as well as to educate you. We hope to continue this trend. We have another very instructive case today, just about everything you could want in a complex coronary intervention, multiple, discrete, diffuse, bifurcation, calcified lesions, including a CTO. All sorts of possibilities are there to treat it. Without further description, let me take you to the Cardiac Cath lab where Dr. Kinney and Dr. Sharma are standing by. Samin, I think if I was to make another contribution, that would be following the guidelines and the recommendations with the grid AUC coming in every case, mandating discipline on ourselves to do the cases exactly as recommended by the guidelines.
Absolutely. I mean, both points you made superb. And again, myself and Anu, and we are two fellows, actually, Maria and Jason, yeah, good. All we can see. So this is actually a truly remarkable, complex case. And I'm sorry we'll start because there was a very important hospital meeting by our CEO. Just to say overall that hospital is doing very good. Mount Sinai did not do well last year, but so far so good. Last 5 months have been very, very positive. So I got stuck in there. But anyway, we'll take it. If it takes a few minutes extra, we'll see. But the case is real complex. If we can show that, we start our presentation. This is, again, CME activity with the target audience, accreditation, and faculty disclosures shown here, and commercial support by various companies here. And of course, the system will be shown in the end that how to download your certificate. So this is the case number 192, as you said, 16 years of uninterrupted transmission, and thanks to you that all 16 years, 192 episodes that you came, flew, whether you are here or you came wherever you were, sometime even out of the country for this third Tuesday episode. So this patient actually presented, 83-year-old, presented a few weeks ago with class 4 angina, negative troponin, and had a 3-vessel disease. Does have COPD, and some factors are shown there, and also has some lymphoma, AAA, and lymphoma mesh to spine. There is some question, chemotherapy, ejection fraction is good. So after the 3-vessel discussion, despite putting a good medical therapy, we did have a discussion with the surgeons, and surgery was declined, one because of the age, and then second, more important point of the COPD and lymphoma. So the patient went ahead and did the PCI of the OM, and with a stage of the LED diagonal, which we're going to show now. If Anu can show, that's the plan today, and very complex. So yes, this appropriate case with a 3-vessel disease and good medical therapy. Yeah.
So this is where we are. EF, which is good, and then the circumflex, right? We decided that the right coronary artery, we'll leave it alone. We did not take a picture, actually. It was proximally occluded and heavily calcified. You can see the entire right coronary artery. So this is where we are with the LED. So calcified.
Angulated too.
Yep. Yeah, calcified LED, proximal, and then just at that level you have that occluded diagonal, which actually when we did the angiogram, it looked like a large size diag. Now it looks almost total as well as small vessel. Yeah. But that's not the thing. The whole entire LED diffusely deceased all the way down. Yeah.
And this case actually, we selected of a dozen cases for our symposium, which was very, very most successful ever. Last Friday with the 11 cases and various kind of complexity. We thought that we keep this patient will require more time. Compared to usually 30-40 minutes we allow during the symposium, that this will be a good for CC's live webcast. Actually, the diagonal, which is large and calcified, was kind of a little channel at that time, maybe 2 RBCs were going. Now it's completely occluded and very angulated proximal LED now. So anyway,
Okay.
it's
So
a little.
here I am with the fielder fine cross. You see that the fielder just making that, and I'm going to see if I can advance, right?
No, but making a for the diagonal ostium.
Yeah. I'm going to the diag. No?
Okay, let's see.
There you go.
You'll need a little
You
stiffer
might.
wire right there anyway. Yeah. Both Gaia versus 6. Usually
Miracle 6.
I mean,
try the 6. Yeah.
7 French guide.
It's a
Yes.
7 French guide. Yeah. Our plan is that if we can get the diagonal, which is a large size, second diagonal is okay. So we may, I mean, second is there, but not big vessel. That is the big one. So we trying to do
There we
kissing
go.
stent. Yeah.
Fantastic job. Fantastic job. Just fantastic.
You think we are there?
I
Oh,
think you are.
But advance the
I think
Corsair.
no,
I
no,
mean,
no, it's not. It's
The
going to
distal
a little
part, I
branch.
think, yeah, distal part, but you are in the main diagonal, I think.
but I would just advance. Yeah.
No, some branch.
So we'll not know till you open the ostium a little bit,
Yeah.
pull back the fine cross, and then take a picture.
Yes,
Is it
let's
Corsair
do
or
that.
fine cross?
No, this fine cross. Ready?
Okay. Yep.
Small
We'll do a long cine. Yeah.
to a balloon or something. Yeah.
Yeah. Right now we just have.
I think the distal
Yeah.
part is in a small branch, but you do.
Yeah.
It
enter
is
the
the
diagonal
diag.
went very.
Yeah.
I think it's very small. No?
No,
I
no.
mean,
Once we
also-
open, will be yeah.
Okay.
Yes.
Also, I want to right up front, as we were
Okay, now
talking
we are
about
Yeah.
16 years of CCC Live, would be amiss if I did not thank our audience. They have grown over the years. We have learned almost sometimes as much as from both of you as the audience.
Exchange
They have
length,
kept
run
it
No, run through, or you want to
interactive.
leave exchange length fielder?
Yeah.
Oh, no.
Hmm.
You have to do rota of the main
Yep.
branch? No, no need for rota.
No, but remember when he talks, we have to be
I
slow.
mean,
Yeah.
Dr. Nagarajan sends his best to you from Canberra, Australia.
Oh, beautiful. Yes. Hello. Yeah. So no, absolutely, because not only that, the journey, as you know, started by the first case. Good. You want to just do a little balloon and then we leave it and then do a rota of the main vessel. Yeah. So key, it started on July and August of 2009. We were alone. Then the Cath Lab Digest took it over very quickly. So we started a partner in by September, and then next year by July, June or July. As you know that we worked through, it became very popular event. Then we got hard.org. Until about 2011, then ACC came in. And of course, the ACC went out by 15, and we thought they will going to go down actually 16. And then to the contrary, our audience, as you just said, so thankful to audience, continue to increase globally, the numbers and the country-wise, and so much so now 180 plus countries, and every month 22 to 23,000 hits.
I've got at the moment an audience from Vietnam, from Egypt, and from Canberra, Australia.
Okay.
All
And tell us
making-
what's happening now. Yeah.
Now, this case is a case to be discussed.
Yeah.
We could even think of leaving the fine cross, not fine cross, the fielder in the side branch. You could then decide, do you want to do rota, or you can just do IVL also of the main branch? So you don't lose a wire of the side branch.
So that's a very good point. But here it's a very calcific LED, as you can see. The
But
question is here.
calcium
Look at
is
it.
only proximally. There's nothing after that.
No, but this is the kind of case you want to leave the wire after opening ostium. Remember, lesion is further down. So we can start the burr exactly when it takes off, the wire takes off at the diagonal. Go, let's
I
see
would
now.
never do that. Okay. And no, you don't need, to me, truly speaking, I think.
Okay,
don't need
first
to do
thing
rota.
first, let's advance this wire, take our fine cross out, take a good picture after vasodilatation, and then decide whether you need to, what you need to do for the main vessel. That's the whole case.
No, that's why I wanted fielder rather than run through. So we could have just left the fielder in the side branch and
No, leave
then.
the run through also.
I don't like the way the wire is
It's a
behaving.
multiple wire.
Okay.
Good. No, but do you want to put this fine cross just to like Fogarty all the way? No. Okay.
It's not
Fine.
going either.
Good. Okay. Fine. So let's take this
Okay,
out
get
one
us
second.
a 2012 balloon, right?
Yeah. 2012.
Yes.
Just put a filter in this one again because we are going to go with the LED. Okay, now let's give a little vasodilator and then we'll give us the branches of that diagonal. So nothing else.
Anu, there's also a very nice point made by Saurabh Augustam. Augustam. I'm sorry for the mispronunciation. And he's mentioning that, look, the diagonal is a small diffusely diseased vessel that can be left on medical management too. Good point.
Yes.
But I think you'll be surprised. I think it'll turn out to be a big vessel. Moderate vessel, not big.
Yeah, moderate.
No, I agree.
Yeah.
But
But let us just at least dilate and see, maybe then we can leave it alone.
Yeah. I would still say that now see that we have little room for the rotor, knowing that it's a conical shape.
No.
I think it could be still okay.
people running with the shortage of equipment globally. So Nikhil Jha mentions there is a shortage of run-through
Yep.
in India.
Yep.
Same here.
Exactly. No, run through right now is okay. It was in the past, and then the fine cross was the shortage one time. There was one time shortage of
Look,
Corsair.
I have my own theory about it. Nobody makes, the companies don't even look at the small amount of money you make through wires and guides, and so they, their focus is on the big ticket items.
But other point is also, let's dial it here. Yeah. Other point is also, here. So the post-COVID, everyone has felt the pinch. The people just don't want to work.
Down.
Many of them have retired, and they just philosophy has changed.
Work from home.
Total philosophy has changed. Not a little distal, no? Okay.
Let's see.
Okay.
Yeah,
wow.
It's a very good size vessel. Yeah, that's is what I had a feeling.
Yeah.
Anu, beautiful job with the wire there. I thought you'll struggle the whole morning with the wire. Excellent job with the wire.
Look, I'm telling you, leave that there. Do not worry. Let's do the cross the LED. We'll use a 1.5 or 1.25 bar for the LED safely. Not a problem. Now, as you know, if you put an 8 French guide, you can put the over the wire system you fine cross or Godzilla and cover that ostium of the diagonal. That's what has been reported in the literature, and then you bring the rotor bar. In this particular case, in my opinion, with no need to
what you can do, place a stand, don't come up to the ostium, be done with the diag and move on with the LED.
But diagonal is total at the ostium.
Which one?
Diagonal is total at the ostium. Yeah, we
that you can consider later.
Okay, second stand, fine. Let's do it then. But I want to teach that this wire can be left and you can do safely rotor ablation.
I will not, that will not be allowed.
So let's get a 2.5 38. What do you want to do?
2.5 38?
Yeah.
Okay. No, 2.25. 2.5?
Okay. Yeah,
maybe it's a big vessel.
Yeah,
so
2.5.
Anu, here, Samin, this is a suggestion coming again from Nikhil Jha this time. Drug balloon and side branch.
Yeah, but remember here you are going to use
a dissection. Yeah.
It's a dissection. Remember, this is a dissection. The key is the drug-coated balloon comes in when there is no dissection. Yeah. Yep. And so this is a dissection. You have to take care. And second, a cost point of view, in America it will be prohibitive because you have to use the 2 overlapping, because the 30 millimeter the drug-coated balloon, you have to use 2 of them, and that will be $11,000. And that's a big no from American reimbursement point of view at this time, because that's the total loss to the institution. And more important here is there is a dissection. So drug-coated balloon only comes in when you have a good lumen and there is no dissection. That's the key.
But
I know the whole country is, whole world actually, is gaga on the drug-coated balloons. I mean, we have not been that much yet. But,
also we have to mention the cost. Remember, we have said that it is sitting in the safe on the 7th floor.
No, but India is only $80. I mean, 800.
A new viewer, I have.
Some
I
right.
want to first of all welcome him,
That's good, right?
Hamid
Good, right?
Shaksavan,
Mm.
and who mentions that look, sure, there's a dissection, but it isn't one of those type D kind of. It's a little small little, and just to quote him, not a malignant dissection.
That is true. Yeah, it's not a type D dissection, but it's a C. And those are the cases where you lose your sleep, whether it can close up. Usually, drug-coated balloon, go a little distant. Drug-coated balloon, your idea is that you remain good in a short and long term. And in this case, you will be worried about that this may close up.
Fielder fan cross for the LED.
Okay. But yes,
I'm sure
yeah.
you will have a
Good.
excellent result
Ostium,
for
ostium a
the
little bit.
LED
Ostium
also,
again.
but I think
Yeah.
the
Ostium.
diagonal is going to be the real gain.
Yeah.
So you're already occluded the LED now by opening the diag multiple times. Yeah, it is.
Yeah. LED was always occluded, and this
No.
is where we are. 6th atmosphere of the side branch. Good. Okay.
Thing is, this guy, we can't put multiple stands. Huh?
Okay. Okay, we will be able to hopefully take out this wire, and then after you recanalize the LED low. Okay, let's take a picture first. This now after the stand. No, advance the wire a little bit. I always say that once your black portion should be distal, otherwise you'll never know the dissections and so in your lesion. You want to give proximal? Okay.
Looking good.
Very good. Yep. Okay. Let's go to the second part. Another challenge is the LED. We're using the same fielder wire and may require little escalation. We'll see.
Yeah, that's a tough lesion to cross also.
Pull back.
Because that's a calcium. Although there seems to be a channel, but there are so many little integrated channels.
So many excellent reviews, and what I have found it quite remarkable that people watch the case very closely, and they are thinking. So here is another suggestion by Nikhil Jha. Why the plan to leave the RCA? It's a large vessel. No, his point is a very good one.
Yeah. That's true. Absolutely true.
I'm going to show you the RC at the end of the case.
Just because of the length of the
reason.
segment, it's collateralized, and the age of the patient. So yes, if a 65-year-old, definitely would have gone with RC also. But right now, that's the plan we have. And then we can decide. I mean, patient never had a stress test before. So will not be reasonable good EF that after true vessel revascularization of the circumflex and LAD in this particular case, then after a few months do the stress test. If you're ischemic in the RCA, more than mild ischemia, then come back for the part 2 will not be a wrong approach. But right now the plan, right now the plan was just to take care of the 2 vessels and manage because of the age also. For this other patient is very active, but age-wise, 80 plus will not be wrong to do because RCA, CTO, no matter what you do, you do have a chance of little higher, complication. And you saw the whole tram track calcium of this right coronary artery. You see in the bottom at 6 o'clock, 7 o'clock,
right.
mega the whole tram track. So the benefit, I would say the risk outweighs the benefit of the CTO in this particular case with the age and all the factors.
Oh, yes. Okay, I may need a miracle.
So that's, I hope that answered Nikhil Jha's question.
Okay, now?
That's satisfactory, So this looks like good.
Yeah, now we are in the right.
Yeah.
Such a wonderful job with the wire crossing.
Let's get a rotor wire.
Maybe in the subtotal.
That's a different direction, and I think
I could be in the subtotal, I guess.
Somewhere around there, I think you
Yeah.
go into the septal, but
Okay, now.
Yeah.
Yeah.
totally different. Yeah. Amazing. No torquer.
Okay.
That's it.
Perfect. Fantastic job.
1.5 bar and 3.0 and 2.5 30 high pressure. You want to leave the wire in there? Okay.
Not. Even that symposium LED, the first case, we had to do the diag, then we removed we thought LED we will do it without. We had to remove the side branch wire and then only take care of the LED.
To me, Samin, when you were mentioning about the successful cases during the conference, I thought there were several reasons which contributed to it. It's not that everything goes so nicely and easily because of the way things were planned.
Yeah.
And the area where I think, which is what you had kind of mentioned on the boat when you were talking, I think Joseph Sweeney this year also lent a great deal of, a reliable person who carried on the tasks very nicely. And
No, all three
Yeah.
of them.
All
We
three.
depend
Yeah,
a
yeah.
lot on
Yeah.
Amit Huda, Parasuram, because all of them trained here.
Outstanding team, outstanding team. And where I think, look, in the few months when we were doing pilot cases for MedStream 360, there was almost a 1 in 4 chance that cases would be cancelled there. And the fact that, the methodology, Anu, which you mentioned about how your PAs and all the staff is constantly looking for the appropriate cases.
No. Let's correct it. They are not looking for appropriate cases.
No,
I look for appropriate cases.
No.
But they follow.
They
No, but they
follow.
follow.
That's
Yeah.
what I was saying.
Not follow.
Keep
They
them
just
engaged.
They
Yeah.
ensure that they are on the schedule.
That's
that
it.
they're,
Yes.
Otherwise, if you look at it, the reason cases get cancelled is, nobody called them, nobody told them, nobody.
Absolutely.
And just to be on top of all of that, I think is remarkable. And I mean, Anu, you didn't hear me saying this for 15 years and 11 months. It is noticing it time after that it is so difficult to do in the middle of you've got something like 65, 66 cases today. To be having just the optimal case where we can educate the audience is truly remarkable.
Yeah. Absolutely. So, yeah. So what happened is, of course, cases are 100% selected by Anu. But then question is,
it's more to it. One, we have to talk to the family. All this is done by me and Dr. Sharma, because talking to the family, talking to the referring doctor, it's a lot.
Absolutely.
Absolutely. It's not working. It was not working. Okay, go.
No, it's working now.
So, Anu, there's another question. What kind of a rotawire do you have? Is this the floppy or?
Floppy,
Yeah, floppy.
Yeah, 90+% our rotawires are rotawire drive. So now the old wires are gone. The rotawire drive, floppy or extra support. And extra support will use in the austere lesion, patients with the ISR, and way distal when you cannot get your birth through, and that give you the support. Yeah. So wire with the curled up, you can pull.
That's okay.
And the wire. Yeah. Good.
Okay, let's do it.
I have also been observing like a overwhelming majority. I think this is a big change which has happened over the last many years. That almost universally you're using a single burst strategy, and most of them are with the 1.5.
That is correct. Yes. And if we would have trouble in advancing the over the wire system, fine cross are there, we would have gone with 1.25. Since it was easy, we went with 1.5. And we know in this day and age, I say that you have to have a region. Yeah. That you have to have a region. That you have to have the region to use the second burr, because then combined with IVL, because will have a lower complication otherwise.
So there are several questions which have come regarding the use of pacemaker.
I don't think we should do here, right?
That's it. Yeah.
So majority of the calcium, you see, it's just in that area which we did.
Not one more polish or done?
No, I don't want to. There could be a bridge later, further down. No, so we'll avoid rotational acceleration in there. Get me run through and filter.
No, one second. No, one second. Don't take the clip
Cannot.
out.
Cannot take the clip out.
Clip, because remember, wire will rotate. You take out only.
Spin inside.
Only, that's the purpose. Yeah.
Okay,
go.
ready? Go.
Sorry.
Run through and filter again. Let's take a picture first. Little bit of EKG changes now. Good, right? Now your EKG
Blood
changes.
pressure is good.
Can you,
Smile,
you know what, Felipe? Put the ceiling camera full. Can you?
Yeah.
And just put the.
There you go. Perfect.
Yeah,
Philip.
yeah.
Okay.
Ay.
No, no,
That's
fall
a-
down. That's right. I'm
Such a
throwing.
magnificent teaching view.
Yep.
Looks like a satellite picture.
Yep. Ready?
Yes.
Okay, see to believe it.
Oh.
Good. Diagonal slowed down, that's the reason.
No, slow. That's why you see some
Yeah.
EKG changes.
Changes, yeah.
That's maybe because of the proximal, right? Okay, let's wire.
Let's go back and see the. Okay.
So we are not. The whole question was that we have the fielder wire. We are going to put in the diagonal, open with the balloon again.
Get me a new fielder because that fielder
Yeah.
is now we used 3-4 times.
Yeah.
Yeah.
So some very strange. The diagonal, I mean, there looks to be a little sludging in the diagonal, but,
Yeah.
the real lesion was, it's kind of in the diagonal.
In the
involvement.
diagonal,
So,
yeah. So I mean, some of the plaque just might have gone at the ostium. We are going to take care of that.
Very, very interesting. If you notice there, this is people have a kind of a formulative idea about it, and now you see it that the sludging happens in a relatively smaller vessel with no outflow, which is what is happening here in the diagonal as opposed to in the LAD, which continues to show excellent flow because of so many septals and diagonals traversing the entire LAD.
Good.
But,
Take the rotor wire out.
Get the fielder again. Let me do the wiring. Get us a 2.5, right? Diag has to be ostium 2.5 now. You want to cut?
Yeah.
Or use just high pressure balloon.
Yeah,
Now what should be the LAD though?
LED, we had 2.530 right now.
275.
Okay.
Yeah, but I think we can go to the bigger one, but this is a 2.5 here. 1 second.
You think one long strand will cover it?
Yeah, no, it's I think more than that. So 2.530 balloon we already have. And the diagonal you want to use what? 2.512?
Yeah. No, so LED you
Or
want to
cutting
put a
balloon.
2.5.
The 2.530 we already opened for the LED. Always we say.
Stent, I'm talking about stent.
Yeah, it's a 2.548 probably first.
I thought you may choose a little bigger size than that,
In the
275.
LED?
No, the distal.
The distal, but then post dilate proximal area to 30 even. What balloon we have now? 2.530, and then we can get a 2.5 shorter one. No, I think non-compliant is okay.
More people watch so
We need to
carefully.
do a mini crush, yeah.
Yeah,
Any-
keep it 2. Keep it 2. You don't. Or can you put the
Anu here I'm quoting
hemodynamics to the small in the side?
it's a relatively insignificant implication of it, but Dr. Jha noticed why the left groin. I'm sure there was problem on the right with some access issues.
No, that was.
Yeah, he had a big right side
hernia on the right side.
No,
Last
very,
time we
very
do
interesting.
we do left radial.
People are watching so carefully. I mean,
Very good.
Dr. Nagarajan had before he picked up immediately. He says, there is a ventricalization of the guiding catheter, and then he noticed a run of bigeminy. So that should put you on your toes. People are watching you carefully.
We like it.
Yeah, absolutely. I thank the audience once again.
Distal.
your interest, your enthusiasm, your compulsiveness only makes us better.
Down.
Samin, it was
Because of
also
distal
fascinating
outflow.
comments
No,
you
I
made.
don't outflow. Maybe it will be here. Let's take a picture before we go on the.
I
There.
wanted to mention that to you, but we both got busy. That when you mentioned that in which country would you have 130 people still watching at the truly ending session, and that
Ready?
happens to be in Japan.
Yep.
The discipline of the Japanese audience, and it's almost like they feel that if they leave, it is disrespectful to the
Exactly.
speaker, and just amazing.
What do you think?
Good. We just do the LED and then we put a mini crash.
Yeah, looking good.
Okay, get us a 2.5. No, get the 2.5 balloon, and then let's do the.
Yeah, LED, lot of diffusely disease.
I'm worried there's a risk of stent thrombosis in this part.
For which one now?
Everywhere.
For the diagonal?
Yes.
No, patient was on the creatinine is good.
Chemotherapy.
Cangrelor,
Chemotherapy.
no?
Yeah.
No.
No, right now patient is on bivalirudin. PRU is 181
Yeah.
on
need
clopidogrel,
for
and you want to always give an additional stronger PTY12. You can give Efficient, Prasagul 30 milligram load, and at least knowing that this, other people, a lot of people will use IV Cangrelor, which is okay also in this point. So you want to use that?
Not me.
We are not a big IV Cangrelor fan. Within our group, a lot of people use IV Cangrelor.
Well, I think it has a very special use in STEMI.
Yeah. Yep. And these complex lesions also, I am actually on the other side. If I ever use anything, I just go with the 2B3A bolus integral, and probably I'm the only sole survivor keeping this molecule alive at Mount Sinai.
Yeah, hold on. Before you go,
Yeah.
some dye so we know exactly where we stand. So we're not. Okay, give some dye. Okay, go. Okay, down.
That's only 8.
Get us 48 stent. 1, 2, 2, 4. Down.
Yeah, this case, I would say
Go.
that we put a 148 stent with the casing, and then if need to be distal, can use a 1 drug-coated balloon, 1 agent, 2.530. That will be reasonable approach.
Well, on the other hand, if you take a look at it, the disease in the distal LAD wasn't terrible. The bigger problem was in the proximal and mid sections.
Yeah.
It's a very nice lumen there. I think
Somehow the diagonal does not having a good flow.
Yeah.
Is
I
it
think
because
because
outflow
the
some disturbs?
proximal, I think the proximal part,
Until we
ostium,
don't stent it.
Yeah.
ostium never got
Yeah. Let's
treated.
do the stent. Good. Let's take it out. We put a 2.5 12 or maybe 15, and then 2.5 48
2.5?
for the LED.
2.75.
Okay, 2.75 48. Also further downward, yeah, 2.75 will be okay. And 2.5 15. Okay, now we are going to mini crush.
You want to do overlap so much?
Which one? For what?
Okay, give. Let's finish it. No, get the 2.515 first. You have it? Side branch?
Let's see how much is the gap. It's about 15.
And then get us a twin pass. I need to give distally of the DAG. Or do we just use that fine cross? This is a 15. So we're going to the side branch. Show us the non-left main mini crush.
So Dr. Jha just asked something I'm not familiar with. Any experience with the dynamic stent at Mount Sinai?
No, they are not available.
But what exactly is the dynamic strength? Who makes it? What are the
That's
features?
that's the
What is-
bioadapter, right? Bioadapter Dynamax. So it basically is the the links comes off after 6 months. So it's a metal stent, but links comes off so that now it becomes a single, and that gives rise to a good vasomotion of the vessel. That and bioadapter data are very solid coming up. So I think we'll hear more and more about it in a simple kind of lesions. It has done very well. Now more complex how it will be. The whole purpose is the vasomotor function of the vessel, which was the original concept of the biodegradable or bioabsorbable stent is coming up within some fashion that what if you have the stent which are interlinked by the metal, but what if the interlink you can just make absorbable, so metal still remain, but then inside they no longer have that rigidity once the link is absorbed. So now you have total good. So now you have the vasomotion of the vessel. And lower late loss, they have shown also lower thrombosis and lower yearly event, because every DES has shown that you have some percent of event every year. So by bioadapter,
Which is
dynamics, yeah.
Anu, maybe a longer stent
picture.
slightly for the diagonal?
Yeah, we are seeing.
No, it's okay. Yeah. No, diagonal is full
Nicely covered.
coverage. Yeah, it's very good coverage actually. I would say LED you pull back a little bit. Yeah, just the LED. It's looking good. Good.
Okay.
Okay, I'm going off.
Once
Yeah.
you have this
Yeah,
stent
diagonal
in the
came back.
diagonal, the
No?
flow will be restored.
Some die.
You'll die.
Yeah.
Just go up.
No, some die for the dag. Yeah. Yeah, I think you're
Okay, good. And I'm still saying that part of that could be that distal, we may not have a good outflow of the diagonal.
Okay.
The 2.5.
It could be that it was thrombotic dag also. So let us just give vasodilator distally.
Okay. Advance a little bit to the diagonal balloon. Overlap.
Yeah, go
Area,
here,
yeah,
high
good.
pressure.
Okay.
Down?
Yeah.
Okay, 1 second. Go here also. Dilate there. Yeah, see that? All under expanded looks like.
So I would say that even let's keep going a little further. Because there's a
We
long
don't know
stent
what
in the
vessel
diagonal.
is. Already you see little.
Anu, I'm dialing 1-800 Kyoto to get Kiski here.
Yeah. Yeah. Ready?
Okay, ready?
Okay.
No.
You need picture?
Some die for the LAD. Just make sure we are good.
Good.
Yeah, I'm going in. Yeah, okay, good.
Diagonal
Now see the
looks
dag
very
is
good.
back.
Yeah,
Going
yeah.
up.
Hey.
Take the wire out.
Wire. Okay, good.
Good.
He probably is watching. He did tell me, I'll be watching. Down. Back to our good old days. Use our eyes. EYE. Eyes. To do the PCI. Okay.
So there is a question here. It would be nice if Dr. Kinney can brief about the EKG changes when the wire passed the LAD.
No, what
sure,
crossed? No.
That time the diagonal went down.
Went down
Went
after we
down.
dilated.
Yeah.
Yeah,
When we dilated the LED, the diagonal went down. That's causing the EK changes. This is the LED diagonal which was total.
Yeah.
But now, of course, acting up during the procedure because got little life. Now going down.
Now getting upset. Why you
Yeah.
keep? No.
Yeah.
Got upset. He didn't stent the ostium. I think now we stented the ostium. It looks good. The only thing that I would want to do is take micro catheter. Actually, we use
Yeah,
it
the
twin
twin
pass
pass, yeah.
that you can use
Yeah.
vasodilators distally. Okay, everything came out. That's good.
Yeah, good.
Looking good.
Okay, let's cross it and then we do a vasodilator. After
Of the
dilatation.
diag
Yeah.
may not happen now. Wait.
First the LED.
Yes.
Let's go to the LED first.
What is happening? He's having some EKG changes. It's a slow flow everywhere.
Everywhere, yeah. Good.
Okay, you may be right. The question is what you need to do. You need to give some.
Now we have the 2O balloon, right? Original balloon for the diagonal which we had.
Nitroprusside.
Yeah. The first one was 2.5.
Now go. That's it. Go ceiling camera. and magnify it. Remove the app from the side.
The same fielder wire trying to go back in. And what is the balloon? Yeah, exactly.
I want to post it with the... What happened is, I think we have a little mega crush situation here, not a micro.
Other question is that do you want a whisper wire? So
No, it's not a whisper wire. If not, then you have to now get us a 3015
Yeah, get a 3015 high pressure balloon anyway.
for the LED.
Give us that. Leave the wire there and let's open the proximal cells. Yeah, little pot. Yeah.
Because LED could be larger than we think it is.
Yeah, I think so too.
Good. Leave the wire and let's do
Okay, now
this.
went through.
Here we go.
But before going with the 2O, I think let's open the LED a little more, right?
No, we have to do anchor. We'll do that. Okay. We needed that.
Yeah. Yep.
But more important is we'll need anchor. 2012 balloon.
Yep.
This is 100% anchor because it's a little bit more crush. Vessels are small, so he may need a balloon pump at the end, I think. Want to give Cangrelor? I'm not, but...
So I think one of the things which we should give in this case then either Cangrelor.
No, but the issue is also his groin, no? We have to make, left side you can close. Oh, yeah, he's a AAA also. Yeah. Leave it. Oh, you can't put a balloon pump. Definitely no.
The AAA 4.4 centimeter AAA. Good. Get a 2, that balloon.
Okay, go up here again.
I think with some vasodilators, he should be okay.
14, 16.
Okay, done. You have a 2012 balloon. Have a 1.2 balloon ready. If this does not go, yeah, don't open, yeah. So now we will leave it here. It's a 3-or. It says don't go too high. LED is not a large. So in these steps, which we normally don't say in a Europeans will always say it, but we don't typically do the proximal optimization of non-left main. But since the LED was proximally large, which we have done, somehow the wire has crossed, and let us see if this balloon will go. You want to anchor?
Yeah, anchor at low pressure.
Yes, if it does not, then we have to recross.
No, or it's a smaller balloon. New. This is the used balloon.
No, this is not a used balloon.
Yeah.
Oh, this is a
2
used
we
balloon.
used before, yeah. So you want 1.5 or what do you need?
1.25.
Okay, 1.25. But EKG changes are settling down.
I think I should recross.
No. Get to the balloon first.
Okay.
Yeah. So we are going with the new balloon now. That was a
Any
used
more
balloon.
questions there regarding these steps of the...
No, people are generally,
watching.
Yeah.
Watching, okay. Like we say, there are multiple permutation and combinations of how to do a bifurcation stenting. But we teach the same steps. So this is an important step. So if this does not go, we recross to a different cell.
Yes.
Okay, now anchor again. So see why I think we should. How the...
Okay.
See there. See that? It's not in the right.
Okay.
You are good. Let me try again. Okay. You go up again. So it is doing this.
A little pot.
Yeah. No. We did a pot already. That's not the thing. Stop.
I would say pull back
See
the balloon at the bifurcation level.
Yeah.
The fielder wire is making 90 degrees.
No, just 1 second. I'll tell you what you do here. Just leave it here.
No. See.
Okay. Then go
That's not
forward.
good.
Okay. Forward the balloon then.
You cannot.
Good.
Also, I think.
No, you have to pull back again.
Let's see now.
Okay.
I didn't recross. Okay.
Maybe
pull
a
back more.
new
Now pull back more.
small
Yeah.
compliant balloon.
No, this is 1.25.
This is a 1.25.
Pull back more. Otherwise 1.0 or 1.0.
You have the Takuro or you have a Sapphire. Which one? So hopefully in a different cell, right?
Look that way, yes.
Philip, there is a request to see the hemodynamics. So when you get a chance, show us
Go up here.
those two.
Go 3 OSS. This is.
So they're going 4 atmosphere only.
So a new physician I have not introduced before, Edison Katana. What about the risk of stent longitudinal deformation? Is there any risk of it here?
I mean, anytime you do a struggle with a balloon, there's always a possibility. And traditionally, as they've shown, Zions have a less longitudinal deformation compared to Synergy.
Yeah. No. Takuro? You see that? It's too much crush.
Yeah.
5 millimeter crush.
Yeah, I think what happened is little
It's a 5 millimeter crush. So.
Yeah, when everything ends, we have the Corsair originally or we have fine cross?
Recommendation for a emerge balloon.
Emerge.
No. We have a Takuro 1.0, then we have Sapphire 1.0.
And what was
Emerge
1.25?
does not come at 1.0. It's 1.5.
Yeah. We don't have Emerge.
And the previous one we tried was 1.25 Sprinter Legend. That's made by Medtronic. Takuro is made by Terumo. And
1.0 Sapphire.
Sapphire used to be by the IVL company. I don't know what's the company name now. Oh, everything is mentioned in the device aid.
Who is that now? Yeah, Orbit Niche.
Who is that?
Japanese.
Orbis Niche. That's
Yep.
the company which.
Okay, now go. No, this is now what are we using? Takuro, right? Takero. Good.
Looks like went in.
A little bit.
Yeah, let's dial it here.
No, you know what? Down. I think it's not allowing this to go. Okay, there. Okay, good. Takiro, good. Okay.
This has done very good job. It's a 1.5 balloon. The
Not
same which they
1.5,
wanted.
1.0. You gave 1.
No, it's a 1.5.
Where is 1.0?
Takuro. There's no Takuro 1.0.
Why you didn't give me 1.0?
No, 1.0 is only Sapphire. Takuro is 1.5.
Down. Down. Okay, it will go now.
Yeah, good.
It's 1.0.
It's a 1.5. Go. Pressure.
So we have
Now we can
went
get
to
2O.
24
Get a 2O.
atmosphere.
Yeah.
Get that 2O balloon down. Yeah. But you did not give unused balloon. Go up.
Now 2O,
Then,
which we had 2O, we can use it. We have
2.5 high pressure balloon at the end. Okay, down. If this also had not crossed, then we would have gone with the Corsair. Go up. Yes. Two balloon.
So this balloon is doing very good.
It is. No, not even that. I think it has some coating also. Right. Yeah. No. Crossing profile and coating. Between the 1.0 Sapphire and this one, plus 1.25 also. All three balloons are good. Now we are going with the 2.0, then we will go with the 2.5 high pressure balloon for the final case.
That's it.
And then we'll decide if you need vasodilator or, right? We can...
2B3A.
2B3A or people will say use
I think one bolus of integrin, just order it, whether use or not.
Okay, can you go?
Yeah.
Okay, now, okay, good, go up.
Which one is that?
Down, 2.0, down. Go up here. Go up, SF.
I think this is the dilatation which was needed.
Yeah. Good. Let's bring both. Do a kissing for this both, and then we'll do final kissing with the other one.
You don't want 2.5?
Yeah, 2.5 we need. Okay.
Good.
And
Go
let-
up again. Go
okay.
up here. I want
Get
to
a
make sure it
2.5
is-
balloon which we had earlier.
Go up.
Yeah.
Okay.
Now it will
down.
be interesting to see the flow now.
Yes.
Okay, let us finish the 2.5. We'll finish the kiss and then we do the final picture.
Samin, you have not forgotten that you have your whole lecture to give.
Yep.
Case is done. What's the time? Oh, 9.
Yeah. Then actually, if it looks very good, they can decide about
You
doing
start
the
the
IVAS.
kiss. No.
No, let's
Disconnect,
do no
disconnect.
kissing. They want a kissing first.
No, they will not. Kissing everybody. Nobody wants
No,
to watch
they want to
kissing. You
see
start.
the flow after kissing. Then we go. And then meanwhile, if you want, it will be a icing on the cake. The audience that you show your imaging IVAS of both the branches.
No. Today we have decided only the eyes.
Yeah.
Good. Okay, go up again.
Okay, just 1 second. Good. Go negative now.
So unyielding diagonal, huh? Unbelievable.
Should have done with the 2 and be done,
I
right?
thought the 2.5 will just.
No, this is a. Okay,
It'll go,
good.
it'll go.
Here we
Okay.
go. Okay.
Wait, down. Okay, now dilate the. I hope you not destroy the LED there. Wait,
Pull
1
back the other
second.
one. Yeah. 1 second.
Oh, wait.
There.
This is always a side branch.
Good.
Guys, disconnect it wrong.
Good. Okay, let's open the side branch first. Good. 12. Now you go.
No. Okay. No, go,
I'm at-
go low. Yeah, you go.
8.
Okay,
Good.
down.
Good.
Want to take a picture?
Yeah. Actually, after a little vasodilatation.
I think it will look perfect.
LED bar further also.
No, we have to see if we need anything or no
I know,
LED.
but no, I know. But little wire the distal edge. You'll never see the dissection. A little bit okay. Good. Yep. See to believe it.
Oh,
Yeah.
Unbelievable.
Mega.
The real gain will come here from the diagonal.
Yep.
This is a very large vessel
yeah.
which was totally occluded before.
Yep. And we call it not a PCI. We call a LED diagonal transplantation. We transplanted the arteries.
It's very good.
Take the wires out. Always the picture, last one, low mag, without moving the camera, longer. If some wire perf, you can see it here.
So just to
There's a little bit, nothing.
This
Okay.
is just to show that if you go to a lab and there's no imaging, that you can do a complex PCI without imaging also.
Yes. All right. This is fantastic case. I saw step by step, and let's go to our little presentation of. So issues about what I'm going to show today, and I go a little fast because they all will be available on our the website. The plaque modification trials. Euro PCR was very big event nowadays, and there were like almost 12 late breaking trials in the structural field and about 14 in the PCI arena. And of course, there must be endovascular, which I did not pay much attention to. So of the various trials which are presented for plaque modification of the Euro PCR interventional, I'm going to show today the 4 trials of the plaque modification. So one is the Bali trial, and basically it was the comparison of lithotripsy versus conventional preparation. Now, only question is, This was done in Denmark and Europe. What is the Bali stand for? We can look into anywhere. There is no description what BALI means.
Go to room
Maybe somebody, our audience might know it and they can tell us. Believe me, we wasted a lot of time. We even went to
I
the...
bet
yeah.
you B stands for balloon.
Okay.
They've
And
used balloon in something.
A
who
and
knows?
lithotripsy. No, we
Balloon
thought
and-
assisted
balloon and-
lithotripsy,
yeah.
balloon against lithotripsy. We had lot of, I would say, skepticism. We had.
The authors had a great time in Bali. That's why they just
Yeah,
wanted to put
that
Bali
may be
there.
it.
No, there's no B anywhere there.
No, balloon. I know, but they maybe just we don't know. Anyway, it was a lithotripsy, was a conventional balloon in 200 patients, and basically clearly with the lithotripsy, low pressure, additional
Which
balloon
room for,
of whether it's a
come on.
rotablation
Here I did it.
or by using cutting balloon were more used in the conventional approach. And basically what they found, the primary endpoint was failed stent delivery, TVF, and residual area stenosis more than 20% were lower in the lithotripsy group compared to conventional. So basically, Bali trial showed IVL did better than conventional in calcific lesions. These are the stent area, which was not much difference. Late lumen loss was identical, but more importantly, procedural complication. First time we have had where the
Done.
perforation was
Fine.
4% with the IVL. Remember, IVL, every trial have 0, 0, 0. And of course, the MI rate, MI was also 0, but perforation in this trial was 4% in the IVL group. This is the first of its trial, which we never saw. Second trial was, again, IVL comparing rotational atherectomy, and this was a imaging trial with OCT. OFDI in the France, IVL versus rotational atherectomy, and compare about 83 patients versus 86, with the final being post PCI OFDI run with a 30-day MACE. Overall lesion length and things were comparable, very severely calcified. These all were the calcific lesions, which I'm showing here. And the same way, the plaque modification, use of additional balloons were higher in the IVL group compared to rotablation, and high pressure more with the rota, and outcome was the stent area was identical in both approach, whether it's a rota or IVL. It's the 5.5 versus 5.8. Primary endpoint was no difference, although malposition was much higher in the rota group compared to IVL. And same fluoroscopy and contrast volume, but dissection was numerically lower in the RA versus IVL. But overall purpose was the stent, you can say the trial was identical between various imaging endpoints comparing rotational atherectomy versus IVL. Now, the perforation, again, as I mentioned, that we don't see perforation except the Bali trial had 4 cases. Here again, the rotablation did have perforation of 1 to 2%, and there was no difference in the death, stroke, or stent thrombosis and other endpoints. This was a acute trial. Third trial was a roller coaster EPIC 22, which compared rotablation with lithotripsy versus laser. So basically, the calcific lesion again, and they found that once you could not cross, then you can use the second device for optimization. And primary endpoint was stent expansion. So you see, in all 3 groups, 10% failure rate. When you started with a rota, or you started with the IVL, or you started with the laser. Now, only difference was the mechanism of failure. In the rotational atherectomy, it was undilatable lesion. And IVL and laser, it was uncrossable. So that's basically was the difference, but overall failure rate about 10%. Now this is interesting to show procedural outcomes were identical, procedural complication, but numerically lower. IVL is 0% compared to about 3% with other strategy. And lastly, on the right side, as you can see, first the stent calcium fracture were identical, but more than one calcium fracture was noted in the IVL group compared to rota and ALCA. The important point of the stent expansion and intention to treat analysis showed rotational atherectomy over better compared to laser, while rota and IVL were identical. So what we learned basically that all the 3 techniques were equal in calcific lesion. And of course, there was no difference. ALCA, the only remain is that IVL and rotational atherectomy performed equally. IVL had a lower complication numerically lower complication, although no p-value difference. But most important in calcific lesion, stent expansion ALCA failed to meet the non-inferiority margin, so does not work. So clearly the laser is not the way to go. And this is what continuation, and this basically was the conclusion of the authors. The last one again, and the modification is the cutting balloon versus conventional balloon. It's the prediction nears IVAS trial from Japan. We know that slow inflation, multiple inflation gets a better lumen of the cutting balloon, and this was basically compare 86 cutting balloon versus conventional balloon 84 calcific lesions, and balloon sizing was less than it was 0.25 downsizing, and then pre-dilatation, and then you do frequently multiple repeated inflation at least 3 times, and then follow this patient from imaging point of view. Clearly you see the debulking. The conventional balloon had a higher debulking, 16% versus 9%, and the pressures were lower with the cutting balloon compared to the conventional balloon intervention. But as far as then the IVAS point of view, the MSA was higher with the cutting balloon compared to conventional balloon, 6.4 versus 5.9, p-value of 0.013. Now, more importantly, what we learned, and we learned from the COPES trial in the past also, that the cutting balloon difference basically was when there was more calcium. So see the calcium arc on the right side, the MSA was 7.1 versus 6.2 in favor of cutting balloon. But if the calcium arc was less than 180, then there was no difference in cutting balloon or conventional balloon angioplasty. Now also, the TVR was numerically lower, 6.2 versus 1.3. And of course, as I said, MSA was more, and the rest of the endpoints were similar. Now, then the focus review of the month was very unique in the sense everybody talks about the medical therapy, and we actually have a kind of a sentinel paper on this field. We all know FFR positive, you should do a intervention, because if based on the FAME2 trial, despite medical therapy, those patients have a higher event rate. We also have learned that even FFR negative lesions, that they do have, like PREVENT trial, FFR negative also, they have higher event rate if the plaque has the thin cap and other characteristics. So what these investigators did, actually senior author is Jagat Narula, and the main author is Lance Gold, who has published a 20+ paper on this field, is that impact of optimal medical therapy, or we call comprehensive medical care, compared to usual care, guided by coronary flow capacity in outcome at 5 years. So this is a paper in succession of many other data which have been presented by this group called Century Trial. And Century Trial basically was the trial of 6,000 patients with a chronic coronary disease were enrolled and then randomized 500 plus each, and then had a PET scanning. So basically we knew that if you have a high PET scanning findings, the decreased CFR, higher the decreased overall PET flow. So those patients will need the intervention, because they have shown data in the past that if you don't do it, the event rate is like triple times compared to if you do it. So with that plan, so hypothesis of the trial was the comprehensive group will have lower sum risk score at follow-up, because you are more aggressive in treatment compared to usual care. And second, which is the most important, is that comprehensive group will have lower MACE at 5 to 11 year follow-up. Now, what does that mean? It's a very colorful pictorial diagram, but I just want to say it's very simple, that what they counted as the severely reduced coronary flow analysis is the CFR less than 1.27, and stress perfusion blood flow is less than 0.83 ml per minute per gram. So they actually have all types of the coronary flow capacity. The pictures have been shown that we know that once you reach to this number, then those patients should go for revascularization no matter what group they are. So what happened is these patients first were randomized in the usual care versus compare group, and then did a PET scanning. And about 5% of patients got the severely reduced CFC, and they had a revascularization. The number was equal in both the groups. But then those patients were followed by aggressive approach, and they have very important component of the comprehensive group management in terms of patient coming, follow-up, aggressive therapy, change in therapy based on the data you have, the cholesterol level, the sugar levels, and blood pressure, and so on and so forth. And of course, we're talking to the patient and availability. So what did they find? That, as you can see here, the risk score change. At the blue in the center were identical when they started, but in the patients in the standard group, the blue, it get worse at follow-up, compared to red, which is a comprehensive risk score, became lower. So what does that mean? With the aggressive management, with a constant continuous follow-up of this patient, you decrease the overall risk factor of these patients. And what it did, it translated into the lower death rate, death NMI, revascularization, and MACE. So very, very important. Compared to our FFR trials, the outcome basically was determined by lower revascularization. And here, this was all aspects of the MACE component were decreased, including mortality in these 1,000 patients. So very, very remarkable. And of course, because there are more clinic visits on these patients. Now, other important parameters, the LDL, HDL, triglyceride, A1C, BP, BMI, exercise score, diet score, tobacco, medication use, some score, many of them were favored the comprehensive group compared to standard group care. So even exercise duration improved in the comprehensive care with the standard care. So the whole question was, is it mediated by, we understood the medical therapy power, they did a good risk factor modification and risk score went down and outcome improved. So second question needed to be answered, that was it because of improvement in the coronary flow? And answer that is no. You see the quantitative perfusion matrix, the basically did not change. Of course, patient who became severe, they went for subsequent intervention, but overall coronary flow perfusion did not change. And of course, those who had revascularization, their CFC changed, and that's why they had a revascularization. And that number was different in the usual care, was compared to comprehensive care. Comprehensive care was 1/3 than the usual care. And this is put into very nicely in a one graphical abstract. Number of cases, clinical visit, PET guided PCI versus continuous medical surveillance, and then outcome below, and reduce some risk factor scores. So very nicely put in one picture. So randomized century trial demonstrated that comprehensive integrated lifestyle modification and medical management towards goal with revascularization reserved for severely reduced CFC, significantly reduced risk factor score, death, MI, and revascularization. This should have added without changing the coronary flow CFC. So let's come back to the point, imaging after IVL versus rotablation for stent expansion. It's first is outcome after IVL versus conventional balloon PCI and calcified lesion. Yes. Then imaging, second point, after IVL versus rota, they were identical, so no difference. The third, RA plus IVL similar, but better than LCA for MSA in calcific lesion. Yes. And so basically laser lost here, and the cutting balloon better than regular balloon in calcific lesions, one thumbs up. And lastly, randomized blinded trial comparing comprehensive versus usual care. And PET findings showed integrated lifestyle modification in reducing death, MI, and revascularization at 5 years. So this is very important. It tells you that you can do a job, imaging guided PCI, but these people will have event follow-ups. You have to be answer or take care of these factors. This actually have been all the point on the guidelines with the rehabilitation, both ACC as well as European Society, that all 8 metrics of your subsequent care need to be taken care if you want to improve the long-term outcome of these patients. So let's go to questions. Bali trial comparing IVL with conventional balloon PCI showed the the QCA versus OCT guided PCI at 6 months showed the following: lower residual area stenosis in IVL, similar failed stent delivery, lower TVF at 1 year, similar perforation rates between 2 groups, and lower primary endpoints in IVL. Answer clearly is this is the only trial which showed higher perforation rate during the PCI in the IVL group compared to conventional. Second, following are the true statement of the roller coaster EPIC 22 trial comparing RA, IVL or ELCA. Similar stent expansion between RA and IVL, similar procedural outcome between 3 groups, similar procedural complication between 3 groups, similar calcium fracture between 3 groups, and similar stent expansion between RA versus ELCA. And answer clearly is E. Expansion was better in the RA versus ELCA group. The lastly, Century trial comparing comprehensive medical care versus usual care in management of CCD guided by PET findings at 5 years revealed the following in the comprehensive group except decreased sum risk score, lower coronary flow capacity, lower death rate, lower revascularization, improve exercise duration. And the wrong is, it's not mediated by lower coronary flow capacity. It's mediated by likely some change in the plaque characteristics, which everybody is talking about, including data have been shown by yellow trial that you change the plaque characteristics. So many of the cases who are FFR positive at time 0, by the change in aggressive medical therapy, FFR become negative in 10-20% of cases. So just to say, the medical therapy will continue to trump our interventional outcomes and rather will be complementary in terms of management of chronic coronary disease patients. And thank you.
Samin, excellent comprehensive review while remaining completely respectful for all the people who presented these 4 trials at ESC that you reviewed at the Paris Euro PCR. They were all very small numbers.
Yeah.
I mean, you know, 50 patients in 2 groups and all that. I mean, those are the kind of numbers you get at 2 months at Mount Sinai. But very, very lovely review. Anu, final comments from you about the case?
I mean, you have seen how we handled. I think the entire diagonal behaved like that because the ostium was an issue. So between LAD and diagonal ostium, you know, there was a lot of plaque probably in that area. And finally, we showed sometimes you need to listen to your EYE also. You don't need IVUS all the time.
Anu, excellent case. Samin, I conclude today's case by quoting somebody. I think that completely and most objectively states our efforts over all these years. This is Dr. Saurabh Agustam. Congratulations to the team for completing 16 years. It's big achievement and Mount Sinai is epitome of knowledge for the world. Hope to see more and more complex cases in the future. Saurabh, thank you so much. We will endeavor to do just that. And Anu and Samin, thank you for an excellent case.
Thank you. And next case will be in July. Yeah.
July 15th, we'll see you back.
Yep.